Hello, I'm Eve Bargman and this is Pat Murray, and we'll be talking today about examination of the heart and blood vessels. As with any examination, we'll start out with inspection, both of the jugular venous pulse and its precordium. Then we'll be examining the heart by palpation and by auscultation with bell and diaphragm of the stethoscope. And last, we'll examine the blood vessels. I'm going to start by asking Pat to lie down at about 30 degrees. And this is the normal angle we'll have to examine the jugular venous pulse. Jugular venous pulse, what you're looking for is the internal jugular venous pulse, which is behind the sternocleidomastoid muscle. You can often see the external above it, but we're actually looking for the movement, which is quite subtle, behind the sternocleidomastoid. You use a pen light for this, and we'll shine it tangentially across his neck, and you can actually see pulsation of the jugular venous pulse just in the supraclavicular fossa. In a healthy person, you won't see it above that level. After we've looked at his jugular venous pulse for a minute, we'll also inspect his precordium and just look for visible palpation, for visible pulsations at all, either at his left sternoborder or at his PMI or apex. And Pat does not have any visible pulsations at all. After inspecting, we'll palpate, again palpating the precordium with the flat part of your fingers here at the left sternoborder, and again at the base, palpating for lifts, as you'd find with right ventricular hypertrophy, or for thrills, which are palpable heart murmurs. And after that, we'll palpate his PMI, or his apical impulse, and that's usually found by drawing an imaginary line down the middle of the clavicle, down here, to a point really just under and medial to the nipple. So right here is where you'd expect to find the PMI. Now Pat has a very easily palpable PMI, but I'll show you techniques to palpate it in folks in whom it's not more easily palpable. First of all, let me get you to roll a little bit over to your left side, just partway over. That's perfect, just like that. And I'm going to put my hand here in that same position, and now breathe out and hold it. Good. That's perfect. Now breathe. Good. And you can get back on your back again. So the exhale and hold it, as well as the left lateral position, makes it more easily to palpate the PMI, or the apex. I'm going to get him down a little bit lower for the rest of the examination. After palpation, good. Are you comfortable there?
Yeah.
Good. After palpation, we'll be auscultating or listening, and we'll listen with both sides of the stethoscope. There are 4 cardiac listening areas. One is the apex, or PMI, where we just were, where you listen to the mitral valve and the left ventricle. There's the left lower sternoborder, which is the tricuspid valve, left upper sternoborder, which is pulmonic valve, and the right sternoborder, which is the aortic valve. And I'm going to start listening with the bell at the stethoscope, which catches low-pitched sounds. It's very important when you listen with the bell to touch it fairly lightly to the chest wall, because if you push too hard, you turn it into a diaphragm. And you'll listen in all 4 areas, but you'll listen especially closely when you're listening at the apex, because it's here that you'll hear S3 and S4, which are both very low-pitched sounds, as well as low-pitched murmurs, like the murmur of mitral stenosis. And after you've listened here for a while, you'll go to the left lower sternoborder. Again, just light pressure, just making contact. Okay, left upper sternoborder. Good. And the right sternoborder. All 4 areas, just listening with the bell. Now I'm going to switch to the diaphragm of the stethoscope, which catches higher pitched sounds, and I'll listen in the same 4 areas again. So I'll start again at the apex, listening with the diaphragm. And as you're listening, don't just put your stethoscope there, really pay attention to what you're hearing. You'll hear S1 and S2, and then listen between S1 and S2 for systolic murmurs and sounds. And then listen after S2 for diastolic murmurs and sounds. And do that in each location. Listen to S1 and S2, systole and diastole. Up at the left upper sternal border, which is the pulmonic area, you'll often hear an S2 that splits during inspiration. So I'm going to ask you to take a slow breath in and then let it all back out again. Good. Wonderful. And just breathe normally now. And that way you can hear, if you're listening to S2, it splits in inspiration, closes with expiration. So that's inspection, palpation, and auscultation of the heart. And we'll proceed now to the blood vessels. Since I have my stethoscope on, I'll go first to the carotid pulse. And you can palpate and auscultate carotid pulse. The carotid pulse is right under the angle of the jaw, and it's easy to palpate. Please only palpate one side at a time. Nice strong pulse on this side. Nice strong pulse here as well. And you'll also auscultate on both sides for bruits, which are sounds of obstructed blood flow in the carotids. Listening for bruits, you usually use the bell. I'm going to get you to take a deep breath and hold it. Good. And now breathe. And now take a deep breath and hold it again. And breathe. Good. It's important to ask folks to hold their breath for two reasons. One is breath sounds are very loud and they will obscure any bruit. And the other is, if they talk when you have the stethoscope on their neck, it's really loud. You don't want this. After examining carotid pulses, we'll examine the peripheral pulses as well, starting with the brachial pulses. And you examine these on both sides so you can compare the two sides always. So we'll examine the brachial pulse. You do this with the arm straight. It's just barely medial to the biceps tendon. Quite easy to palpate right here. Medial. And the radial pulse, which is just in the hollow of the wrist, just proximal to the thumb. Use several fingers here and use the flat part of your fingers. It's better for palpating vibration. Okay. So that's radial pulse. Thank you. And good. Same thing here. Radial pulse on this side. And brachial pulse on this side also. Nice strong pulse. Quite medial here. Good. So for the popliteal pulses, use all your fingers. They're not always easy pulses to feel. So the flat part of all 8 fingers. Flex the knee just a little bit and bring the fingers up underneath. Use a little bit of pressure. And he has a very nicely palpable popliteal pulse. Good, thank you. Same thing on the other side, all the fingers, a little bit of a flexed knee, moderate pressure, and again a very nice popliteal pulse. Good. And then last, the pedal pulses, dorsalis pedis and posterior tibial. For dorsalis pedis pulse, keep the foot even a little bit dorsiflexed, and it's just a bit medial of the midline right here. Nice strong pulse here. Again, check the same on both sides. Good, nice strong 2 pulse on this side as well. Posterior tibial is just where it sounds like it's behind the tibia, behind the medial malleolus, right here. And again, palpate with several fingers, and it's right here. On him, nice strong pulse. Same thing here. Palpate with several fingers, and it's right here. So in conclusion, we inspected the jugular venous pulse and the precordium. We palpated the precordium and the apical impulse. We auscultated in the 4 cardiac listening areas with both bell and diaphragm of the stethoscope. We palpated and auscultated the carotid arteries, and we examined the peripheral pulses, brachial, radial, popliteal, dorsalis pedis, and posterior tibial. Pat, thank you very much.
You're welcome.